We're going to review some of the skin infections now. We'll start off with impetigo. Impetigo can be the bullous or the non-bullous type. Non-bullous, look for honey-colored crusted lesions. It is usually caused by Staph aureus, also the group A beta hemolytic strep. The same family of strep that can cause strep throat, well, you can also have skin strep that can cause skin lesions and impetigo, and don't forget strep with rheumatic fever and glomerulonephritis. The bullous lesions are usually Staph aureus. We are seeing more and more methicillin-resistant Staph aureus now, causing skin lesions and abscesses in children. The treatment or the bullous Staph aureus can actually progress to staphylococcal scalded skin syndrome. We mentioned that as in the neonate as part of the differential diagnosis with erythema toxicum. The treatment of localized impetigo is usually just topical. Mupirocin is an excellent choice on the lesions. Widespread impetigo, you should use oral antibiotics, and don't forget you absolutely have to cover for staph, so use something that has a beta-lactamase. This is the honey-crusted lesions that I was describing of impetigo. This child has quite a few of them right there, so this child probably would merit oral antibiotic therapy. Don't forget you can get secondary impetigo from scratching, for example, with patients with atopic dermatitis. Here is some of the bullous lesions that we talked about. That's one that has not burst yet. Here's one that has, and so you'll see some areas of denuded skin. Cellulitis, deeper layer now. The loose connective tissue will have some limited involvement of the dermis, but we're working our way in, and this can cause cellulitis. And again, think of strep pyogenes and Staph aureus. The margins are somewhat indistinct and kind of blend into the surrounding tissue. You can try blood cultures. You can also get what's known as a leading edge culture, but we pretty much know that it's going to be staph and strep. You should always cover for those, both of those organisms. Here we have a child. You can see almost like a bullous lesion of impetigo, but you can see these areas that are deeper and redder, and then you see this area of demarcation here. This is cellulitis. The erysipelas are even deeper layers infected of the skin, so it's the underlying connective tissue. These will have sharply defined, slightly elevated borders. They can have high fevers associated with it. Since it's a deeper layer, they can appear a little bit more toxic. You can culture the area and also get blood cultures. And again, remember staph coverage. And here we see a patient with deeper layers and actually extending to the eye almost, and that's why you have some erythema there. And it comes all the way down. See that clear demarcation right there of the erysipelas where there's the deeper layer and then there's not any layer. Staphylococcal scalded skin syndrome, as we said, we alluded to it in the neonate. It is also by Staph aureus, and it is hematogenous spread. Remember, we discussed what's known as Nikolsky sign, not pathognomonic, but it's when you rub your finger in a linear fashion and that area just blisters up like a burn. And these, especially in the neonate, these patients can be very toxic very fast, and they can have shock and hypotension. They will have a diffuse scarlatiniform erythema. They will develop blisters. They can have crusting. Remember Nikolsky sign, and then denuded areas after the skin peels off. The bulli that are intact are sterile. We try to leave those alone, actually. Obtain cultures from any site of local infection. A blood culture can be helpful, and the treatment is going to be, in this case, IV antibiotics. Oral antibiotics for staphylococcal scalded skin syndrome are inadequate, and so you need to use IV antibiotics. Be careful, these act like a burn, so fluid and electrolyte management is very important with this disease. Folliculitis is an infection and inflammation of the hair follicles, and again, it's usually Staph aureus. You will see pustules at the opening of the canals, and it can occur in the scalp, also buttocks and extremities. This is many times associated with poor hygiene. The diagnosis is made on gram stain, although once you see the characteristic lesions, you just go ahead and treat for Staph aureus. Furuncles and carbuncles are deeper layers, and it can occur secondary to folliculitis. Look for the hair-bearing areas. Infected hair follicles get into the deeper layer. Again, think of Staph aureus. Predisposing conditions include obesity, also hyperhidrosis, any areas where there's friction, typical of obesity, and also patients with diabetes are at higher risk for furuncles and carbuncles because they have some immune problems also. The treatment is to keep clean, use antibacterial soaps, try to wear loose-fitting clothing, try to aerate so that the air stays cool and well ventilated, and again, consider using drugs that will cover staph. Tinea versicolor is a fungal infection of the skin. It is usually caused by Malassezia furfur. The predisposing factors include a warm environment and a humid environment. So in the summertime is when you're really going to see it. Also excessive sweating and occlusion, so it's trying to stay cool, dry, and clean really helps. It's mostly seen in adolescents and young adults. The presentation of tinea versicolor varies depending on the race. Sometimes you can have hypo or hyperpigmented lesions. Sometimes the hypopigmented lesions you'll see get worse or look worse on sun exposure because the area around tans, and then that area that actually has the infection doesn't tan because of no penetration of the sun's rays because of the infection there. And so they look more prominent after you've been out in the sun. Here we have a patient with multiple areas, all of these hypopigmented areas everywhere. That is tinea versicolor, and it's usually just a clinical diagnosis. You can do the wood lamp exam, and sometimes you'll see some fluorescence, and you can do a scraping and a KOH, and you can actually see the hyphae of the, because it is a fungal infection. Treatment is usually topical with selenium sulfide solution. You use it every day and just put it on topically on the skin. The dermatophytoses include trichophyton, microsporum, and epidermophyton. Predisposing factors for these fungal infections include skin trauma, higher temperatures, excess skin hydration, immunodeficiencies put you at higher risk. Also diabetes puts you at higher risk for any of these infections. The diagnosis, you can actually look at the infected hairs. You can do what's known a wood lamp, and Wood's lamp is like a UV light, and they fluoresce, but not all fluoresce. The trichophytons do not fluoresce. You can also do KOH prep and or a culture. A lot of times you can just look and make your diagnosis. Tinea capitis is one form of the dermatophytoses. This is going to be caused mostly by trichophytons. And again, microsporums fluoresce, trichophytons don't. So the Wood's lamp may not be helpful in that case. You can also have a specific kind called black dot carrion, black dot tinea, even tinea capitis. What happens is that the hair shaft gets infected and it breaks off right at the level of the scalp, and so you see these tiny little black dots at the scalp, and that's the actual hair shaft that you're seeing on cross-section because the rest of the hair broke off. The treatment here is going to be griseofulvin. A carrion is actually, can fool you. It looks like an abscess, but a carrion is actually an inflammatory response to this infection. And so the treatment for the carrion is not an antibiotic because these are fungal infections. So you treat them with the oral griseofulvin, but that patient also needs steroids, and that helps to calm down that inflammatory response of the carrion. And it feels like a boggy mass, and you can be fooled into thinking it's an abscess. So here we have a patient with a carrion, and it's right here, this area right there, and you can palpate that, and it looks real, it's real mushy, and you think it's an abscess. And that's just a granulomatous response, inflammatory response to the tinea. Tinea corporis what we call ringworm. Some people call it tinea corporis, some people call it tinea circinata because of the ring-like appearance. This is going to be a rash that presents anywhere on the body, but it will be with central clearing, a raised red border, and it's very scaly. It kind of looks almost like Lyme disease, but Lyme disease is not scaly or have that red raised border like this does. It does clear centrally, and again, this will is usually a diagnosis that you make just by looking at it on recognition, and you can treat it with topically. With topical antifungals. The hair, the tinea capitis, you do not treat topically. It will not get better unless you use oral medication. And this is tinea corporis, or ringworm. So you see that area right there, that border is elevated. You can sometimes be fooled with another entity called granuloma annulari, and that is actually an inflammatory response. We don't know really what causes it, but it will not clear with the antifungals. Tinea cruris, everybody calls that jock itch, and this is another fungal infection in the groin area, mostly seen in adolescent males. It'll be in the inner thigh, and it'll spread, and you'll see irregular patches. It will have severe pruritus, and again, clean, dry, cool, and topicals. Tinea pedis is the athlete's foot. Lots of commercials for that. It's seen mostly in adolescent males. Look in the toe webs. It itches. You can have fissuring. You can have peeling of the skin. And again, keep don't wear occlusive footwear. Keep it nice and cool and aerated. You can try keeping it dry, and you can use topical treatment.